Hi, I'm Michelle Kittleson, Professor of Medicine at the Smith Heart Institute at Cedars-Sinai and Associate Editor for JACC. I'm delighted to be joined today by Dr. Scott Solomon and Dr. Marianna Fontana to discuss outpatient worsening heart failure in patients with transthyretin amyloidosis with cardiomyopathy in the HELIOS-B trial. The study will be presented at the American Heart Association scientific sessions with simultaneous publication in JACC. Dr. Solomon is Director of Clinical Trial Outcomes Center at Brigham and Women's Hospital, Edward D. Froelich Distinguished Chair in Cardiovascular Pathophysiology and Professor at Harvard Medical School. Dr. Fontana is Professor of Cardiology and Honorary Consultant Cardiologist at the National Amyloidosis Center of University College London. I cannot think of two more expert discussants for this very exciting manuscript. So to set the stage, the HELIOS-B trial was a randomized controlled trial of Vutrisiran versus placebo in patients with transthyretin cardiac amyloidosis. In an amazing win for patients with ATTR-CM, Vutrisiran was associated with a significantly lower risk of the composite of all-cause mortality and cardiovascular events. Treatment with Vutrisiran preserved functional capacity and quality of life. So we are going to talk about the results of a pre-specified analysis of HELIOS-B. First, I'm going to start with Dr. Fontana. Can you summarize the results of this study that will appear in JACC?
Thank you so much, Michelle, for the very kind introduction of the study. And as you mentioned, this is a pre-specified analysis of the HELIOS-B trial, a large randomized trial in patients with ATTR cardiomyopathy. And what we try to do here is really to analyze the whole spectrum of worsening heart failure. As in clinical trials of heart failure, endpoints which are very widely recognized and then be used for a long time are urgent heart failure visit and cardiovascular hospitalization, heart failure hospitalization. But the problem with that is that they don't capture the whole spectrum of heart failure, like worsening heart failure in the outpatient settings. And that manifests most commonly with initiation of loop diuretics or worsening or increasing the diuretic dose. And so what we're trying to capture here is the whole spectrum of worsening heart failure, from urgent heart failure visit, heart failure hospitalization, but also worsening heart failure in the outpatient settings with initiation or intensifications of the loop diuretic. And so we confirmed the strong prognostic significance of worsening heart failure in the outpatient settings with a strong correlation with mortality and cardiovascular events. But also we showed how once the patient experiences outpatient worsening heart failure, then they've got a significant decline in the functional capacity, quality of life, and also biomarkers. But most importantly, when we assessed the effect of treatment, we saw how Vutrisiran was associated with significantly lower worsening heart failure in the outpatient settings. And also we've seen how incorporating that in a composite together with cardiovascular hospitalization and mortality significantly increases the number of events, and so could increase significantly the power of our clinical trials.
Very exciting. So we should pay attention as clinicians to oral diuretic intensification or initiation in our patients. And as you mentioned, there are also clinical trial implications. So Dr. Solomon, can you tell us how you think this might affect the conduct of future clinical trials in amyloidosis?
Well, thanks, Michelle, and thanks for talking with us about this this topic, which has been of interest to me beyond the area of amyloid for quite some time. As you know, as we think about clinical trials in heart failure, if you go back only about 20 years ago, the only endpoint we cared about was all-cause mortality. And then we started, of course, adding to that heart failure hospitalization. But as you well know, as we try harder and harder to keep people out of the hospital, we start treating them more and more effectively as outpatients. And sometimes we treat them in the urgent care setting. And most of the heart failure trials today are actually incorporating not just heart failure hospitalization in the composite endpoint with mortality, but also urgent heart failure visits. So we've done that in the major SGLT2 trials, for example, DAPA-HF and DELIVER. But this particular endpoint that Marianna just mentioned is even an earlier endpoint for our patients. It happens at an earlier time in the course of their disease. And of course, we're trying to keep our patients out of the hospital. We're seeing them in the office. We're treating them as outpatients with oral diuretic intensification. But of course, this has meaning as well. And it has meaning in the trials because for two reasons. One, it's a marker of the patient getting worse. And the second is that it can actually affect what happens to the patient. If you treat a patient with oral diuretics as an outpatient, you could actually avert a heart failure hospitalization. And if we don't incorporate this potentially into our endpoints, we could actually even miss endpoints in our patients. So I actually think that it has implications for trials as a whole. We've looked at this in the SGLT2 inhibitor heart failure trials and see the exact same thing, that there's prognostic value to this endpoint and there's discriminatory value. It helps us discriminate our therapies. And in amyloid, where we don't have the numbers that we have in the general heart failure trials, I think it could be very helpful in increasing the number of endpoints and therefore increasing the power with a meaningful endpoint. Now, the question is it as meaningful as a heart failure hospitalization? Well, probably not, but it is an endpoint that does mean something to the patients, and we think we should be at least measuring carefully in our trials.
That's super helpful. It's so lovely to have that historical perspective when we couldn't do much of anything. We really just focused on mortality, but now we've gotten so good at taking care of patients with heart failure that we can fine-tune our approach and get better and better, earlier and earlier in decompensation. So now I'm going to turn it back to Dr. Fontana for the last question we're going to close out with. So as a clinician, of course, I'm so delighted that we're likely going to have a new medication in our toolkit for our patients with cardiac amyloidosis. And we know in HELIOS-B that about 40% of patients in the trial were receiving tafamidis at baseline. And the pattern of risk reductions were comparable in the overall population, the monotherapy population, the baseline tafamidis subgroup. And do you think this offers any insight into the role of stabilizer versus silencer or both in patients with ATTR-CM?
Well, thank you so much, Michelle, for this question. I think since the publication of the HELIOS-B results, this has become an extremely topical question in every single Congress. This is a question that really everybody's focusing on. And the reason is because we know from the ATTR trial that is the trial that changed everything for patients and for physicians working with these patients, that tafamidis, so a TTR stabilizer, was extremely effective in patients with this condition. However, there was full acknowledgement that also this patient continued to progress. So there was a residual risk which was left. And what we know from the pathobiology of amyloid is that there is a very good correlation between the magnitude of knockdown of the new amyloid production and outcome. And we know that with stabilizer, we don't achieve 100% stabilization of the protein. So from a pathophysiological point of view, there was already this hypothesis that combination of drugs with stabilization and gene silencer could virtually achieve 100% knockdown in the new amyloid production. And this is because with a gene silence, for example, we reduced the production of 80 to 90%, and then with the TTR stabilizer, we could stabilize the rest of the protein left, achieving virtually 100% reduction in the new amyloid production. So even before the publication of the trial, there was a lot of hope that actually combination treatment is probably the way to go for the future. And I was really pleased to see that everything, as you say, pointed in the direction that there was an additive effect of Vutrisiran on the background tafamidis patient. So adding a gene silencer on top of stabilization, it seems that it's leading to an added benefit. And so the future could really be combination therapy. So I'm really looking forward to more research in the field because similarly to what we saw in AA and AL amyloidosis, so in the other form of amyloidosis, the more knockdown, the better to patients. And I'm absolutely certain that the same will be in ATTR amyloidosis. And so combination of stabilizer and silencer, I think, will be really the optimal treatment strategies in this patient population.
Amazing. I feel so lucky to have two of the greatest experts in clinical trials and amyloidosis here for our JACC readership to get the latest and greatest insight into this really important trial. I want to thank you so much for your participation.
Thank you, Michelle, for the invitation.
And keep sending your manuscripts to JACC.